So good morning, everybody. Welcome to the Grants Rounds. Now I have the special pleasure to introduce Dr. Luc Mertens. He's the new head at GU of Pediatric Cardiology. Luc actually earned his medical degree in Leuven, Belgium, followed by a PhD in molecular biology and physiology. He actually did his residency in pediatrics and pediatric cardiology in Leuven and at the Mayo Clinic. And in 2008, he was actually recruited as director of echocardiography at Sick Kids in Toronto. In 2013, he was promoted to full professor at the University of Toronto. And last year, in April, we had the great pleasure that he accepted to move to Ottawa and to take over, as you can see, as medical director of the cardiovascular program and division head of cardiology at the Children's Hospital in Ottawa. He's very well known for all his publications in cardiac imaging, especially in echocardiography. He authored, I think, a couple of textbooks about echocardiography in adult congenital heart disease. He's very well connected. He is very well known for his research. He is the lead in different heart and stroke research grants. And so it's really an extraordinary opportunity for us to profit from his experience. And so he will give us a talk about, as you can see, a lifespan approach to congenital heart disease towards prediction, early detection, and prevention. Please. Look. This is the microphone.
Thank you, Marcus, for this very kind introduction. And I thought, since we're neighbors now, it's always nice to invite your neighbor over. So I thought having a neighborhood party may be nice. So it's nice to be here at the Ottawa Heart Institute. After a year being in Ottawa, I think it's a nice opportunity to meet in person and to get to know you a bit better. So it's a great pleasure to be here, and thanks for the kind introduction, Marcus. So what I'll try to do to you is I give a more general talk about more philosophical and general about congenital heart disease. And actually, at the end, you see how that's linked to what we're trying to do at GEO right now, and how to rebuild the cardiac program there. You mentioned I trained in Leuven, Belgium, and this is a little statue in the city center of Leuven, and it's called Fons Sapientia. It's the Latin word for the source of wisdom. And you see, you pour the wisdom into your brain. By the way, Leuven is also the city where Stella is made. So you can interpret it as the source of wisdom, whatever. It's also a big university city. The little statue is reading a book with a very complicated mathematical formula within the book. And if you resolve the mathematical formula, which requires you going to university, it gives you the word happiness in Dutch. So it's a very deep statue. And I hope I can give you some wisdom today in whatever liquid or not liquid form. What I will try to do is to see, and I've been involved in that within heart and stroke, how you can develop a strategic vision for congenital heart disease patients across the lifespan, and also how we try to develop a strategic vision for the cardiovascular program at GEO. I mentioned heart and stroke, and this is an initiative that started about 3 years ago now, where Heart and Stroke funded an initiative to develop a strategy for congenital heart disease patients in Canada. They did the same about 10 years ago now for heart failure. That resulted in a big heart failure initiative with a lot of initiative across the country for managing heart failure patients. And their idea was to do something similar for congenital heart disease. So a lot of the things I'll be talking about is actually inspired by some of the work we've been doing in the context of that national initiative. If you think about congenital heart disease, it's quite common. It's about 18,000 newborns are born with heart disease. So it's it is not under the umbrella of rare disease. What I've seen happening over the last 30 years, I've been in this field for more than 25 years now. What I've seen in this field is very remarkable, like you've seen in the field in cardiology in general, is the incredible improvement in survival. When I started training, operative mortality for congenital heart surgery was in the range of 15%. Currently, if you look at last year's results from the SICKITS program, which is the largest program in Canada, the operative mortality of congenital heart surgery is within the range of 1 to 2%. So this is an incredible achievement, reducing that mortality by this degree that took this creation of heart centers, of teams working well together to improve outcomes for patients. It required teamwork. That was the secret sauce of reducing that surgical mortality in current centers. And SICKITS treat all complexities because they're the major center in Ontario. So they have to take every patient. So it's not based on selected patients like some of the US centers do, because if you only operate on the easiest patient, it's not that difficult to reduce your mortality. So that's an all encompassed complexity. So that means also, because of this increased survival over the last 20, 30 years, you see that now the majority of patients living with congenital heart disease are adult patients, as Marcus well knows, because he's probably not bored here since he joined the group, because I'm quite sure he has a long waiting list of congenital patients waiting to be seen by him. So this is an exploding field because of the results in pediatric heart disease management. So what we also then have to realize is that we're shifting our focus because we've achieved survival. The 1 to 2% patients we cannot save. They're typically very complicated patients who have a lot of additional diseases associated with the congenital heart disease that probably have a very poor survival, whatever you do. So there is not a lot of gain to make in that 1 to 2%. But where we can make a lot of gain is to shift from this survival to now look at how can we improve long-term outcomes? How can we improve the patient's health span and deal with some of the problems they encounter living with congenital heart disease later in their lives? Because the majority of patients you see in adult cardiology are very different. They develop disease later in life. Here, you're confronted with a disease you're born with, and you have to live with for the rest of your life. So how do you improve your health span? That's the main question we have. So what we know, and there's definitely a lifelong impact on the cardiovascular system of being born with congenital heart disease. And we know that those patients are at risk for definitely significantly increased risk compared to the general population to develop heart failure, arrhythmia, and stroke, which probably are the three most common problems they develop over time. This only increases when you age, and that's what you're familiar with, because they're born with a disease, and on top of that, they can acquire additional disease. And I don't have to tell you here what the important comorbidities are for this patient population. Development of hypertension, associated diabetes, obesity are the things that not going to improve their long-term outcomes and their long-term health span, because their risk of acquired heart disease increases significantly. We also learned over the last decades that congenital heart disease is not only heart disease, and that there may be a multi-system impact of the disease you're born with. And the higher the complexity, the higher the risk that you have associated problems with other organs, brain, a significant issue in the patient population. We learned, we're looking after. So we've learned to look at congenital heart disease more and more as a system disease, to think about how the disease can affect other organs? How can it affect different aspects of a patient's life? And how can you help and support them through this? We know, and this is out of general research, and this is a nice publication on congenital heart disease across the lifespan from Gerald Diller and Ariane Morelli from Montreal, where they looked at the factors that can influence. Because if we want to improve health span, how can we influence that? And there are different factors that influence health span in general. We learn more and more about the genetics influencing health span and the impact of the environment on the interaction between environment and genetics and epigenetics, as we call it, and how that can impact health span. The environment is important. Socioeconomic status, lifestyle especially, can influence long-term health and long-term outcomes. And then there are the things we do as physicians, the medical interventions, the associated problems they develop and how we manage them and prevent them, and how we prevent complications is really important and determines how the patient lives through the life. The real question is, and this is out of the same publication, how can we influence that health trajectory? How can we influence that? How can we bring patients with congenital heart disease where their health trajectory prematurely gets down the cliff? How can we bring them to a general population trajectory? How can we improve their health span across the life? So that brings me to the key questions you have to answer when you want to do that as a profession. The first question can we predict the patients? Can we predict the patients at risk for developing adverse health trajectories? So it's all about health prediction. Can we detect adverse health trajectories early? And can we prevent that unfavorable health trajectory? So those are the three key questions you have to answer if you want to address the question of improving health span. So number one is prediction, and we are developing and
so you're doing the concussion and what was here?
Teams. Can you please all mute your mics on the Teams, please?
It's okay. I'm used to those problems on Teams. Okay, thanks. So the first question is prediction, and the current use of AI results in definitely coming up with hopefully better prediction models for our patient cohort. And you see the first nice publication, there's nice work for the Brompton, where they developed prediction models based on AI and large data sets from the Brompton Clinic. You see those big prediction models coming out for patients with congenital heart disease. But they're still very primitive. And it will take a large collection of data from different centers, with including genetics, metabolomics, different types of omics before we will come to more reliable prediction models. So that's definitely a strategy for congenital heart disease research, is to develop those prediction models that can help predict patients at risk for developing adverse health events. Early detection is another important research field, and that's where I personally have invested a lot of my career in imaging and see whether we can develop biomarkers that detect adverse outcomes and can predict adverse outcomes. And especially at the cardiac level, can we come up with markers for damage to the myocardium? And that's the advanced techniques we're currently developing, looking at myocardial properties that that change early, shear wave imaging, and all the novel imaging techniques that can detect changes in the myocardium very early on, and hopefully can help predict patients who have damaged myocardium. On the prevention and the intervention, we have come up from a medical perspective with a lot of non-invasive interventions, and we're still learning on when to timely intervene for patients with congenital heart disease. We have to learn not to do things too early, and also not to do certain intervention too late. Other important strategies are thinking about prevention strategies, lifestyle interventions, working on diet, exercise, sleep, preventative, other preventative healthcare measures, developing newer drugs for prevention of cardiac damage. The newer drugs that you're using currently in heart disease can be translated to patients with congenital heart disease, and use of state-of-the-art technologies. What we have to understand, however, is the impact of disease at different stages in life. And in contrast to the diseases you're treating, this starts in fetal life, where patients are living in a fetal environment with a heart defect that can actually impact their overall fetal development, their brain development, and can cause damage to the fetus even before they're born. We're learning a lot about that by development of fetal cardiology. Then we've also realized that that transition from fetal life to newborn life is an important one, where you switch your circulation from a fetal circulation to a newborn circulation. And if you're born with heart disease, this is a critical phase where a lot of problems and damage may occur. Your heart grows, and during childhood, there's a lot of changes in physiology and how growth affects heart disease, and how heart disease affects growth is an important topic for research. In adulthood, there's the impact of aging. And as I'll show later, we've learned that aging occurs faster in patients with congenital heart disease. There's an accelerated aging process, which we still need to understand better, and understand better on how we can intervene. So those are important topics to address if we want to improve outcomes. So how do we do that? And in our field over the last decade, we focused on specific topics, because you cannot focus on everything at the same time. And one of the main problems we noticed is if you look at our population with congenital heart disease, that there's a very high incidence of neurodevelopmental problems. So how can we improve that? Because if we make them survive, how can we make them smarter as well? So better understanding of the heart-brain interaction. And I look at Peter in the audience, who is actually focused on that in the adult population. But it's even more important in this patient group of pediatric patients who have heart disease very early on. How can you improve their brain outcomes associated with their heart disease? How can you improve their brain health? I mentioned already the impact of aging. And how can we develop strategies to slow down that accelerated aging process? And that's probably the best we have for now by lifestyle intervention. And we develop strategies in our field to try to train our kids to live healthier. Because we work with families to try to do that, and we develop systems for doing that. And that's what we focused on with the Heart and Stroke Foundation. How can you develop an integrated healthcare system that actually treats them the way they should? Let's zoom in on the heart-brain connection. And as I already mentioned, the patients are at risk during their entire lifespan, from fetal to adult. We know that they're at higher risk for developing brain problems. And that starts in fetal life. And we know that fetal circulation is very different. And we are learning about the impact of heart disease on the fetal brain. And what Sikits has done is one of the pioneers in fetal MRI, looking both at circulation by fetal MRI as well as at the brain at the same time. Because it took some ingenuity to develop MRI because the fetus moves a lot. So the fetus swims, is in a very different environment. So it doesn't lie still and it's very small. So there were some imaging challenges associated with being able to study that. But that was made possible. And you can even measure flows within the fetus. You can even assess the saturation within the blood by fetal MRI. So you can measure oxygenation, you can measure flow, and you can look at how that changes when you have different types of congenital heart disease. And what we've learned is that indeed there is a relationship between brain growth and congenital heart disease. And that children who have significant congenital heart disease develop smaller brains already during fetal life. So they have a problem, especially in the 3rd trimester during fetal life, where their brain growth slows. It slows down. So that's an observation. Brain growth is affected, especially in the 3rd trimester. But why? So what determines that? And is there anything we can do to prevent that? Because if you're born with a smaller brain, and I'll show that later, that affects your intelligence later in life. So why is that? And I mentioned we can measure oxygenation. So we can measure the oxygenation within the brain. And what we found in the studies we did is that there's a relationship between the estimated brain weight and the cerebral oxygen supply. So oxygenation seems to be, not surprising, seems to be driving brain growth, but you have to prove that it's actually true. And some congenital heart disease, already during fetal life, will result in lower brain oxygenation. So there's this relationship between cerebral oxygen supply and brain growth. So we know that if you have significant congenital heart disease, fetuses develop smaller brains. And when we also look at brain structure, it's different. So their cortical gyrification is different. They have a less organized white matter, and they have an immature biochemistry and electrical activity when you studied it in more detail. And we know that's important because there's this direct relationship, and this nice studies, multi-center studies now done for looking at the relationship between the brain volume and the long-term neurocognitive outcome. Because you can ask the question, does it matter to be born with a smaller brain? Is this just a variation? But it matters because it determines how you perform on the functional scales. Those are the Bailey tests you do at 2 years of age. And there was a nice relationship between test results and brain volumes at birth. So we know that there's a relationship between brain growth and intellectual development and neurocognitive outcome later on in life. So more studies that looked also at blood flow. And that's not surprised because in fetal life, you can measure your combined cardiac output. Fetal circulation, both pumps mainly pump into the systemic circulation. So you have to look at your combined cardiac output. We know, and that's not surprising, for your survival, your combined cardiac output is important. For your brain growth and neurocognitive outcome, there's a direct relationship also to SVC flow, which is the amount of blood flow coming back from your brain, and neurocognitive outcomes and brain growth. So it's not only cerebral oxygen delivery, it's your total brain supply and how much blood flow goes to the brain that will determine your brain growth. But obviously there are other factors, and we are learning more about associations of different mutations, of different genetic abnormalities that can be associated with congenital heart disease. And there's a link between genetic abnormalities and congenital heart disease. So it's not only oxygenation and blood supply to the brain that determines brain growth, but there's an impact of genetics. And there's also, and that's something we sometimes forget, because now we detect congenital heart disease during fetal life. We tell parents relatively early on during their pregnancy that they will have a child with significant congenital heart disease. That definitely is associated with maternal stress, which then negatively also impact brain development. So something you have to consider when you talk to parents: how can you reduce their stressors? How can you improve the overall pregnancy management? So that's what fetal prevention strategies are being thought of. Can you develop fetal interventions that optimize fetal flow dynamics? And we've become more aggressive with fetal interventions. There have been trials. Can you improve oxygen supply to the brain to improve brain growth? There have been trials by giving the mother oxygen and see whether that positively impacts brain development within the fetus. We've learned that there's some dangers doing that. It was not a real good idea to do that, and those trials were stopped. But we're thinking of alternative strategies as we learn more and more about different drugs that could favor, positively influence placental development, other types of strategies that could potentially positively influence fetal growth. So fetus, we pay a lot of attention in fetal cardiology. We see our patients multiple times during pregnancy, prepare the parents for what's going to happen after fetal life, and plan treatment immediately after birth. That postnatal period is very critical. I mentioned already that transition. And now we're doing studies where we actually start monitoring brain perfusion immediately after birth in babies with significant congenital heart disease. And we see that there are important changes that are happening in brain perfusion and oxygen supply to the brain immediately after birth, not surprisingly. And those changes, and how can we optimize perinatal management as much as possible to prevent impact of what we do and what happens immediately after birth in the transitional circulation? How can we prevent additional brain damage? So we have this ongoing, what we call transit study, that looks at the transitional circulation immediately after delivery in patients with congenital, significant congenital heart disease. And especially we noticed that there are important differences between patients who have a right ventricular dominant circulation in how those adaptations happen immediately after delivery. So, and we have to probably manage those patients differently. Because what we learned is that neonatal brain is extremely vulnerable. And we've done studies where we have now brain studies during fetal life, brain studies before the surgeon touches the patient, because we always blame the surgeon, because that's what we do. It's always easy to say when something goes wrong, it must be the surgeon. So what? That's how it happens. So it was, we to prove that it was not the surgeon, we did the studies where we actually looked at fetal brain, the brain before the surgeon did the surgery, and what happened to the brain after surgery. And we noticed that a lot of those brain damage that we knew was present in brains in patients with congenital heart disease was actually already present before the surgeon touched the patient. So it must have occurred in that period between fetal life and surgery. So the first week of life, typically for critical congenital heart disease, when we operate on this patient. So those serial studies where we looked at brain MRIs identified the real risk period. Obviously, long bypass surgery will have impact on the brain, especially when it's that vulnerable in the neonatal period. So what we learned, and that's that up to 10 to 30% of the brain changes we observe in patients with congenital heart disease are present pre-operatively and occur between fetal life and the pre-op period. So in that transition period. And in up to 50% of patients, we see some changes after surgery. So definitely there's an impact of the whole peri-operative management, but that's more complicated because your patient is not only the bypass that will impact brain damage, it's what happens in your ICU, this low output state patients go through the first hours after surgery. So we're focusing a lot, we zoomed in a lot, how can we improve brain protection in the neonatal period? So we learned prenatal detection definitely is protective. Timing of neonatal surgery, if you don't have to do a surgery in the first weeks of life, it protects your brain not doing it. If you anything that you can postpone until 2 months is probably better for the brain. That's what we've learned. It's not because you can do it that you have to do it. So the early postoperative ICU management, where we learned to optimize hemodynamic stability and exposure to certain drugs, are the things we're focusing on from a brain protection perspective. Then optimizing the home environment. Because if you look, and we've learned that from premature babies, what is the most important determinant for the outcome of premature babies who are at risk for developing neurocognitive problems? It's the home environment. That's not surprising. It's the education level of the parents. So how can we optimize? It's the same for congenital heart disease. There are no surprises in life. It can be mitigated. The risks can be largely mitigated by socioeconomic background. So then you go through life, and we get in adolescent life. That's a challenging period because there are a lot of brain changes occurring. We're learning more and more about the impact of congenital heart disease on neurocognitive functioning, all those skills you need to have in life to manage problems. Because your problem-solving skills are the key skills you need in life to manage life. We all are exposed to problems, and how you manage them is going to determine our quality of life. And we notice in congenital heart disease patients is that processing of problem solving is impaired in up to 15–30% of patients with congenital heart disease. So we're setting them up for problems in adolescence because adolescents as such struggle with that. And how you manage patients with congenital heart disease who have problems with problem solving is a challenge, both for parents, for the environment. They're not the easiest patients in general to go through adolescence. Attention deficit disorder is 3 to 4 times more prevalent in patients with congenital heart disease compared to the general population. So you add that on top of less cognitive reserve, I would call it. You reduce your attention, and attention deficit can be an important problem in this area. So that results in a higher risk for mental health problems, which we don't deal with very well. We started recently at SickKids with a screening program for mental health in our congenital heart disease population, where we use, it's done by our nursing team, a short survey, and up to 30% of our patients mention mental health problems based on that survey. So it's quite impressive. We're struggling what to do because you can detect it now, but then if you refer to psychiatry, you have to wait 3 years to get in. So so it's a problem from a health system perspective on how you manage that. What we also know is that you have white matter microstructure cognition problem in adolescents and young adults with congenital heart disease. And that, Marcus, you know that very well. Also in the adult population, you see when you do intelligence testing that they're skewed towards the left. So they are all in the lower range. The majority of patients, you have a shift in this Gaussian distribution in congenital heart disease. On top of that, we know that they're at higher risk to develop earlier dementia. And Peter, that's where you will have to do some work to look at that heart-brain interaction in this patient cohort. So I mentioned the effect of aging. You have accelerated aging. They have higher, this is a nice study from the Mayo Clinic, where they looked at also their cardiovascular risk factors in adult congenital heart disease patients. So a lot of them, as they age, they develop this, they have this additional risk factors for acquired heart disease. So that's where prevention comes in as an important topic. And we know the factors that drive that, and that's the same for general cardiology. It's oxidative stress, inflammatory activation, glucose metabolism, lipid disorders, hypertension, and then there's nothing you can do about telomere shortening. So how can we improve longevity or health span in patients? What are the modifiable and factors we can influence? Lifestyle intervention in children, we've instituted early lipid screening, and then there's the health system approach. That's why we focus in congenital heart disease world now on lifestyle intervention programs. How can we keep them healthy? We saved their lives, we invested a lot in them. Now, how can we help them to stay healthy? Because that's probably the best investment we can make to improve their long-term outcomes. So we developed programs, and this is Dr. Barbara Cifra from Toronto. She came to my door one day. She was a sports medicine doctor from Italy, looking for a job in Canada. And I said, well, I have something nice to do for you because our kids are very inactive. Can you help us to develop a program that actually activates them? So an exercise medicine program. So she did that, and she did that very well. And she did it so well that she was asked at Toronto General to do the same for patients with adult congenital heart disease. So she developed, identify what are actually the lifestyle gaps and how can we help patients to live healthier. And it's not surprisingly physical activity, sedentary behavior, nutrition, sleep, and overall quality of life. So she developed this lifestyle medicine program, and I won't go into the details of that. It's a 6-month program where they work with patients to train them to live healthier. And when you look at the overall patient cohort, a lot of them were referred because they were sedentary and they had high lifestyle behavior problems. So you look at this cohort of patients, and she's followed up to 700 patients with congenital heart disease. So this is just based on about 700 patients. 91% of them were below the physical activity guideline standards, 75% above the sedentary behavior guidelines, 39% with poor nutritional habits, and 25% not matching recommendations for sleep for age. So if you look at the impact of the programs, after 6 months, there was significant improvement in the different things you worked on: physical activity, screen times, diet, and other factors. So those lifestyle programs, and we spend a lot of time now, also in the transition period, to about 2/3 of my clinics is about prevention. Work with patients on preventative strategies for their life. If you're doing well from a cardiac perspective, what's going to put them at risk is developing acquired heart disease. So I'm working with patients, and that's about 2/3 of the time I spend with parents and children, talking about those lifestyle things and the essence of that. The Canadian Pediatric Society just this year launched lipid screening recommendations. So early detection of lipid abnormalities is important for prevention. And as obviously we're working on the health systems approach. So this is the work that came out of, and hopefully will be published soon, out of the Heart and Stroke Foundation on how to come up with a health system approach to patients with congenital heart disease, where we develop this integrated care models. So I hope I convinced you that, from pediatric cardiology perspective, we work more towards the prevention strategies to prevent problems later on in adult life. Now I'll briefly talk about what's the CHIO program. I've been in Ottawa for a year now, and learned a lot about the GEO program. And this program, as Hugo knows, has a long history. And actually, for those who are not aware, there's a government mandate that was issued in 2004 that the cardiovascular surgical program at GEO is a one program, two sides approach with the Sigid's Hospital in Toronto, which is the big center in Ontario. Ontario has 16 million people. And if you think about it, that's quite a lot. If you look at most systems in the world, and with a public health system, if you have a population of 16 million people, you probably have 2 to 3 congenital heart centers and programs. In Europe, they're centralized in certain countries, like Sweden has 6 million people, has 2 congenital heart disease programs because of the size of the country as well. Now, talking about Ontario, is about 3 times bigger than Sweden. So the distances are quite significant in Ontario. If you look at Australia, which is quite big, has about 40 million people and has 6 centers. The United Kingdom, 80 million people, has 16 centers for congenital heart disease. So it makes sense from a government perspective to think that you probably need 2 centers in Ontario where you can provide congenital heart disease care for children. But that's been a rocky road to get there. And that's because of the geographical location where people live in Ontario. So it's been a rocky road, and that's a problem for surgical volumes. And this was towards the end of the program because it's paused, as you know. It's paused since 3 years now. And the number of cases, about 100 total cases with about 50 to 60 pump cases a year, is probably not enough volume to maintain a surgical program at high quality. So that resulted in an external review that recommended some volume recommendations that ideally you should do about 80 to 100 pump cases a year, because that's been shown to reduce surgical mortality. So that's a challenge for smaller centers. How can you maintain your skills to continue to operate at low mortality, at low morbidity? So what we learned, and this is data from the Society of Thoracic Surgery, is that some smaller volume centers can have excellent outcomes. And this is just a graph representing that. This is the surgical what you actually look at is the observed versus expected mortality. And this is based on the national database, the Society of Thoracic Surgery, Congenital Heart Disease database, where they looked at outcomes of congenital heart surgery. You see that the long-term, the observed versus expected mortality is obviously very good in large programs. Large programs do very well. In smaller programs, you see that you can have programs that have very high observed versus expected mortality. So you see that you have more variability in smaller programs. But then you can also see that some of the smaller programs that do less than 100 cases per year have better outcomes compared to the bigger centers. So they perform better. So the question is, how come? How come that some programs that are smaller do better than the big programs that have more experience? What is the secret sauce of a small program? And not surprisingly, if you look in more detail and doing currently more detailed analysis, what determines outcome is teamwork. It's how well you work together as a team. And I already mentioned what changed outcome in congenital heart disease is the creation of teams. Because what we've learned is it's not, because we used to blame the surgeon when something was going wrong. And we said, the patient didn't survive because the surgery wasn't well done. But this is always nonsense. It's the whole team that looks after that patient and manages the problem that's going to determine your long-term outcome. It's the pre-operative diagnosis. It's the management team within the operating room, your nursing team, your perfusionist. It's the ICU team. and how it interacts with cardiologists, how it interacts with the surgeon, and how it manages problems and how it saves patients when there is a problem. That's going to determine your outcome. So it's creating of the teams and creating in a smaller center a small team that is well gelled. That's going to determine your long-term outcome. So how well can you put your hands together and work in the same direction? So that's how we came to the idea, like how can we truly institute and execute this one program, two sides approach between the SIGIT's surgical program and the CHIO program. So what we've done and we agreed on between the two organizations is to use a phased approach to actually go back to starting surgery at CHIO. First is you need to do the team development. So we start from scratch and redevelop the team at CHIO, both cardiology, ICU. We are redeveloping surgery, we're redeveloping the team. And while we're doing that, we pause surgery until we feel that the team is gelled enough to restart surgery. In the second phase, we'll restart surgery collaboration with the surgical program at SIGIT, then to gain more independence in the third phase. So that's the strategy towards congenital, to restarting a congenital program. The progress today is that we've created an overarching SIGIT CHIO steering committee. We've created different working groups that are being launched over the next couple of weeks to look at specific problems. We also hope, and that's why I'm here, to partner with the Ottawa Heart Institute. We are living in the same city, looking after patients with heart disease, how we can partner with the spirit of this is a disease you live with for the rest of your life, and they will become all your patients, and they will become all your problem. So it's better to partner early on. I started with a statue, I end with a statue. So you've seen this spider. Have you ever wondered what it represents? It's called Maman. It's called Mummy. So it represents motherhood. And it actually, the artist, it's a funny story actually, the artist had a mom who worked in the tapestry industry. So she was a weaver. And so for her, a spider symbolized motherhood. So that's how she came up with those spiders that she put across the world, because they're in Bilbao, they're in different cities. And it's nice to have one in Ottawa. Thank you for your attention.
Well, thanks a lot for this really inspiring talk and also the highlighting sort of collaboration between the Heart Institute and CHIO. Are there any questions from the audience so far? If not, you stress the lifespan approach, and you said there are different stages. There's the fetal stage, there is the neonatal period, adolescence, adulthood. If you have, let's say, to pick a stage, what stage do you think has the most potential actually to improve the lifespan perspective of the congenital heart disease patients? I know it's a tricky question, but what would be your guess or your say?
That's where I think the most vulnerable period you target first. So that's a strategic approach I would use. You put your money where you're most vulnerable. So the most vulnerable period in life is that transition period. I think there's probably not a lot we can do fetal life during at this moment. So I would say that's probably where if I would have an opportunity, that's where I would put a lot of money. But that's going to be hard to intervene. Because we all learned from the hyperoxygenation studies that you have to be careful doing that, to make sure that you don't cause problems when you intervene. So it's easier to target, and that's where we're putting a lot of money right now in that transition period and newborn period, because we know that's where a lot of damage happens, especially to the brain and also to other organs. But then I think the mistake we're making is not investing in prevention. And I think the real money maker is prevention. Yeah, and you probably know that in adult, you probably know that, Marcus. There's a big difference in patients with congenital heart disease who have a healthy lifestyle versus those who do not. And you know that out of your practice. I practice adult congenital heart disease at Toronto General as well. That was my observation. If people are active and lead a healthy lifestyle, they are just healthier. It really impacts their life very significantly. So if I would put my money somewhere, it's in prevention. And that's where I put my money in my clinics.
Yeah.
Because I know that if I can convince someone to live healthy, that's going to have the biggest impact, more than anything else I can do.
I just check briefly on the chat if you have any questions in the chat. There are no additional questions in the chat. So I think in this case, if there are no further questions, no question. As a surgeon, you agree with the fact that it's not the surgeon that is to blame. I think it's really a team approach. And I guess that's really, I think, also what you're looking forward in the collaboration with Geo, to have a team approach on a lifespan perspective. And so it's really great to have you and to explore the opportunity of collaboration between Geo and the Heart Institute.
Thank you.
Okay, so in this case, wish you all a nice morning. Thanks for joining us and have a good day. Thanks. Bye.